Good afternoon. Thank you for the kind invitation to present our talk today on cancer of unknown primary. And my name is Dr. Anna Varghese. I'm a medical oncologist at Memorial Sloan Kettering Cancer Center in New York City. And I work within the GI oncology service, although I have a particular interest in cancer of unknown primary. So first, we'll just briefly discuss definitions of what cancer of unknown primary is, as well as different types of cancer of unknown primary, our diagnostic workup for cancer of unknown primary, as well as prognostic factors, treatments, and future directions as we look towards advancing treatments in this unusual and often challenging diagnosis. So first, just what is cancer of unknown primary? It also goes by occult primary, which in the NCCN guidelines here in the United States, there is a category for occult primary. There's also sometimes people call it CUP, which is just the initials for cancer of unknown primary here in the U.S. at least. And in the NCCN guidelines, it's defined as, quote, histologically confirmed metastatic tumors whose primary sites cannot be identified during pre-treatment evaluation. So essentially, we know that when it's a situation when we know there is cancer there, but it's hard to determine exactly where the cancer may have started. So next we'll discuss how we diagnose this disease, both based on the pathologic workup as well as the imaging. So first, for the pathologic diagnosis, cancer of unknown primary often represents a very heterogeneous population in which there are many different kinds of cancers of unknown primary. And the initial histologic categorizations usually fall into one of these categories. First, just poorly differentiated carcinoma, which represents generally about 30% of the patients that we see, followed by adenocarcinoma, which is probably the majority of patients that we see, followed by smaller categories of squamous cell carcinoma, as well as neuroendocrine carcinoma. For the initial immunohistochemical evaluation of cancer of unknown primary, there are some just initial stains that are usually very helpful as we start making some very initial distinctions for patients when we first meet them after they have a biopsy performed. And this is from an excellent review from Pavlidis in the Lancet in 2012, so now many years ago, although I still think quite relevant. In terms of just initial immunohistochemical tests that we'll perform for categorization of cancer of unknown primary, first, just trying to clarify, is it a carcinoma, lymphoma, melanoma, or sarcoma with initial IHC stains with AE1 or AE3 or S100 and HMB45, which can often help us clarify a diagnosis of, or at least lead us towards the path of melanoma, as well as S100 and Vimentin for categorizing for a sarcoma. We do have clarity that the diagnosis is carcinoma, then there's additional stains that can be very helpful as we make further distinctions among adenocarcinoma, germ cell tumor, hepatocellular carcinoma, and the others as listed here. And often some of the most helpful stains, although there's so many tests that can be ordered, and I'm not a pathologist by training, and I'm a medical oncologist, but often some of the first stains that can be most helpful once a diagnosis of carcinoma is confirmed is CK7 and CK20, which just based on the patterns of those stains can often give us some clarity as to where the cancer may have originated. But then there's additional tests including PSA, RCC, CD10, TTF1, and thyroglobulin, and of course the neuroendocrine markers of chromogranin and synaptophysin that can be very helpful. And this chart is certainly one, at least as a medical oncologist, probably not to be memorized, but can be an excellent resource. If a diagnosis of adenocarcinoma becomes more clear based on these stains, then often these distinctions or additional stains can help as we try to make some more clarity for diagnosing where the cancer may have started. But sometimes, again, even with all of these stains performed, we end up with a situation where it's hard to tell exactly where the cancer may have started. And again, CK7 and CK20 alone can often, just based on the patterns of those alterations, can often be very helpful, as noted here. And these patterns, again, colon cancer or lower gastrointestinal tract primary cancers are often following this pattern of CK7 negative and CK20 positive. Upper GI cancers are often CK7 positive and CK20 positive or negative. And in biliary cancers, also often pancreatobiliary cancers, I should say, often CK7 positive, CK20 negative. Lung cancers, often CK7 positive. And I think that's often, just given the demographics of cancer, at least in the United States, certainly lung cancer is by far and away the most common kind of cancer that we often see, particularly in the metastatic setting. So an unusual CK7 positive cancer, always want to think about lung cancer, particularly in a person with tobacco exposure. Some CK20 positive, CK7 negative cancers, often again thinking about lower gastrointestinal tract cancers, urothelial cancers, and this unusual cancer of Merkel cell carcinoma. And this is very much a situation where working together with your pathologist can be most helpful and important as we try to help clarify where a cancer may have started. We look next to the sort of diagnostic workup, laboratory and radiologic workup that's usually recommended for cancers of unknown primary. Initial laboratory tests, really just a simple complete blood count and comprehensive metabolic panel is usually where I start. Many people will ask me or will have come to see me as a second or third opinion, having had many, many lab tests run, including many tumor markers, including CA19-9 and CA125 and CEA and many others. And, although those can be sometimes helpful in leading you down certain paths, truthfully, they're so nonspecific. I don't know that they necessarily help make a diagnosis for anyone, but they can be helpful as another way for monitoring. But in terms of a diagnostic workup, truthfully, I don't usually myself find them that helpful, although many times people will have had them ordered. And certainly not wrong to do so, but I don't know that it necessarily, again, makes a diagnosis for you. In terms of imaging workup, CAT scans of the chest, abdomen, pelvis with contrast are really just good high-quality cross-sectional imaging is also what we usually recommend, as well as symptom-directed endoscopy. And I highlight this symptom-directed because, sometimes when we meet patients with cancer of unknown primary, one of our initial instincts is just to order every kind of test you can, whether that's an upper endoscopy and a colonoscopy and a cystoscopy and so many tests that can be ordered. But really, I do encourage people to be judicious with the tests that we order for patients because patients are often unwell in these situations when they're newly diagnosed. So we do want to be careful with all of the tests that we put them through. And additionally, based on the immunohistochemical staining and symptoms that patients have, that can often really give you some clues as to what kinds of tests are going to be most useful for you. For instance, if you have a patient with anemia and change in their bowel habits and a CK20 positive tumor, that should certainly get you thinking about a lower GI tract cancer like a colon cancer or rectal cancer. So perhaps a colonoscopy, but an upper endoscopy may not be necessarily that useful in that situation. So really this relatively basic workup here is what we usually recommend in terms of initial diagnostic evaluation for these patients. Another test that's so often ordered for these patients are PET-CT imaging or PET scan imaging, in which patients have patients and clinicians certainly are very hopeful that this imaging will help identify a primary site of disease. In truth, though, in the NCCN guidelines, though, PET scan is not recommended as part of the initial imaging. I suppose unless there's, a patient's unable to get good high-quality cross-sectional imaging, perhaps they have renal failure making, CT contrast not feasible, or perhaps an iodine allergy making CT contrast not feasible. But for patients who can get good high-quality cross-sectional imaging, PET imaging isn't necessarily as useful as we might hope it would be. This can be a challenging area to study, but there have been several meta-analyses to try to help us answer these questions, and this is one of the largest ones from Kui and colleagues from the European Journal of Radiology from 2009, in which they sort of pulled together in this meta-analysis and review 433 patients across 11 studies, and what they found was 37% of the time were they able to identify a primary tumor. But you can see here a very broad range, 22 to 73% across these different studies, which I think again only highlights the heterogeneous nature of this disease, as well as the different kinds of workup that patients may undergo when they are diagnosed with cancer of unknown primary. So in this study, the most common primary sites identified were in the lung, oropharynx, and pancreas. And for those of us who are seeing patients, not surprising to see many common false positives in also the lung and the oropharynx. And certainly PET imaging is not the best imaging for primary breast cancer, but that's a common place for false negative rates. Again, in terms of endoscopic testing for patients with cancer of unknown primary, these studies should really be performed to evaluate symptoms or to follow up a specific pathologic feature. So for instance, if someone has, a dominant lung mass and a tumor that's CK7 positive and also TTF1 positive, which is often a pattern seen in primary lung cancers, and the person has a tobacco exposure, consideration of a bronchoscopy or further sort of lung-directed testing or imaging very reasonable. Likewise, for a patient who has a CK20 positive, CK7 negative tumor and also presenting with new onset of anemia or change in bowel habits, for instance, with constipation, colonoscopy is very reasonable for that patient as well. But I wouldn't just recommend doing all of these tests for everybody with cancer of unknown primary. A common question that comes up for patients and for clinicians, and I think for all of us, is just, well, when are you going to find the primary, or how often do we get to find the primary site? So again, this is from an older study from 2007, but this was another meta-analysis evaluating 884 patients from 12 autopsy studies from a very wide range here from 1944 to 2000. And of these patients, even at autopsy, 73% had a primary identified. So here in this study, a majority of patients did have a primary site identified, although it does give me some pause, although it's hard to know exactly what kind of diagnostic imaging and testing might have been done, in the mid-20th century as we approach now, as we're beginning 2022 now. So this is a meta-analysis that is there, although I would take it, although I would be cautious in how we apply this information to our patients in a modern day setting. There was another slightly more modern meta-analysis with a review of 12 studies performed between 1967 and 1983 of just over 2,000 patients. And of these patients, 27% of them had an autopsy, and of those, 20% had a primary site identified. So in this study, I think a much less finding of patients identifying a primary site disease, again, even at autopsy. So we often try to help our patients sort of move beyond, certainly if there is a diagnostic workup to be done based, again, carefully on patient symptoms, as well as other diagnostic tests that maybe make certain primary sites more or less likely. I think if we're not able to find a primary site despite our best tests, sometimes we're really in a position where we need to move forward with thinking about treatment planning, as patients can often, again, be very unwell here. So we do try to do our best to identify a primary site, but really if we're not able to identify one, try to move forward as best as we can with the information that we have. So as we think about the predictors of poor survival for patients in cancer of unknown primary, unfortunately, this is a disease which can have historically difficult, poor outcomes. And some of the predictors of particularly poor survival include histology of adenocarcinoma, patients with worse performance status with an ECOG performance status greater than 1, as well as some additional laboratory findings that can sometimes be prognostic, including low serum albumin and elevated LDH. And part of this comes, again, from a nice review from Varghese in the Lancet from 2012, as well as a very excellent review from Dr. Varghese from the New England Journal of Medicine in 2000. Generally, patients with cancer of unknown primary, although it is a very heterogeneous population, often fall into one of a few different categories. So And these are some situations where we want to make sure that we think about certain primary sites because there are some patterns and ways that we can help identify and take care of patients. So for patients with a poorly differentiated carcinoma, primarily with disease in the midline, as well as, and if they are generally men or less than 50, you always want to make sure that you thought about an extragonadal germ cell tumor, as that can be a disease where we are aiming to cure patients. So certainly we want to make sure that we've identified and thought about those kind of less common scenarios. Like additionally, in a woman who presents with an isolated axillary lymph node, that should really be treated as breast cancer until proven otherwise. And in fact, there was a manuscript demonstrating that an occult breast primary cancer was identified in 72% of these women who underwent mastectomy in the setting of presentation with an isolated axillary lymph node. Similarly, a patient who presents with squamous cell carcinoma involving primarily lymph nodes in the head and the neck, like for instance with cervical lymph nodes, that should also be treated as a head and neck primary cancer with an occult primary. For people who present with just ascites, and it's not without an obvious gynecologic primary site, those are often treated as if they're arising from the gastrointestinal tract. Patients, I think, who present with metastatic visceral or skeletal cancer of unknown primary, unfortunately, this is probably the majority of the patients we see, and again, often can have poor outcomes. But we'll talk about different ways to approach those patients in addition to the standard chemotherapy regimens that we offer. So again, for patients with localized carcinoma, for instance, disease presenting primarily in the head and the neck, those should be treated as if they were head and neck cancers. Likewise, for people presenting with isolated supraclavicular lymphadenopathy, in which a diagnosis of cancer has already been confirmed, women who present with axillary lymphadenopathy only should be treated as if they have breast cancer. And want to again make sure that we consider the possibility of germ cell tumor for patients in the right demographic with disease primarily in the mediastinum. For patients with widely disseminated adenocarcinoma and squamous cell carcinoma, chemotherapy, cytotoxic chemotherapy really remains our primary treatment for these patients, including this most common regimen of carboplatin and paclitaxel, cisplatin, gemcitabine, FOLFOX with 5-FU, with 5-fluorouracil, leucovorin, and oxaliplatin, also an excellent combination, particularly if there is some suspicion for a gastrointestinal primary. Additional combinations can also be considered. The combination of gemcitabine and docetaxel, drawing on the experience of our colleagues taking care of patients with sarcoma, can sometimes be considered if there are sarcomatous features to the carcinoma. And again, platinums combined with 5-FU, similar to the FOLFOX regimen, could also be considered. I think another question as we move forward, and it's sometimes disappointing in 2022 to think, is chemotherapy really all we have for these patients? And truthfully, often it is. But I think trying to figure out if there's a way to include more modern technologies in these treatments is often where we're looking towards for the future and for now, truthfully, for patients with cancer of unknown primary. There are these gene expression arrays that are available, at least here in the U.S., where patients can have tissue sent to a company that performs this testing based on the gene expression patterns, they might identify a certain primary site that seems more likely. Although these tests are available, and I think certainly many clinicians do order them, I don't myself order them frequently. They're not recommended in the NCCN guidelines, and I often think there's better uses for that tissue, particularly if we only have limited tissue available, and we'll talk a little bit about that. I'll skip this manuscript as we move forward to other kinds of testing that, again, I do think is probably the better use of tissue. So as we have seen in so many other cancers, including particularly in lung cancer, but also in upper gastrointestinal tract cancers like stomach and esophageal cancer, and many others, we're seeing that there is a shift in the ways that we choose treatments based not only on where the cancer is starting, but really based on our understanding of the underlying cancer biology. And that is where we focus on the presence or absence of targetable alterations in conjunction with identification of a primary site. So there was this manuscript in JAMA Oncology in 2015 based primarily from the group from the Foundation Medicine, in which 200 cancers of unknown primary underwent next generation sequencing. And what they found was 169 out of 200 had one or more potentially targetable genomic alterations. And I think if you look in the details and if you're interested in this manuscript, one certainly could take some argument about what they're calling potentially targetable alterations, as I think in practice, truthfully, I don't know that I see the majority of patients having genetic alterations that are amenable to treatment with targeted therapies. And we published our experience on molecular characterization of patients with cancer of unknown primary for patients seen between 2014 and 2016. And of 150 of them who had had molecular testing, more like a third of them had targetable alterations. But I think what was disappointing, that was a third of those were able to receive targeted therapy. I think just highlighting the challenge of taking care of these patients where sometimes they are so unwell that we're not always able to use all of the treatment options that are at our disposal. But I think does highlight the importance of doing this kind of testing, as it is a sizable minority of patients who have targetable alterations. And I think doing this testing sooner rather than later, so that hopefully we can get these patients to at least try those therapies to see if they may help. And particularly as we move forward towards additional drugs that are being approved now in sort of agnostic of where the primary cancer may have started, this also is more evidence for us to try to do further genetic testing for these patients, and again, do it earlier in their disease course rather than later, so that hopefully they have the opportunity to attempt those kinds of targeted therapies. So these are 3 drugs that in the last several years have been approved based primarily on based on the presence of a targetable genetic alteration. For instance, in this paper by Drillin and colleagues from Cancer Discovery in 2017, the drug entrectinib, which was shown to be helpful for patients with particular genetic alterations. Likewise, and again, follow-up studies here with entrectinib for patients with NTRK fusions. And then also PD-1 blockade or use of checkpoint inhibitors for patients with mismatch repair deficiency only, regardless of where the cancer may have started. Again, all more evidence for us to try to do this kind of testing for patients. And I had this patient presented to me, and I think highlights the importance
Dr.
of doing
Anna,
this kind of testing.
1 minute left, ma'am.
Thank you. So this was a 60-year-old woman who presented to her primary care physician with shortness of breath, night sweats, and weight loss. And she was found to have hypercalcemia, and tumor markers were notable for the slightly elevated CA19-9, although not particularly high. I think our range was 0 to 35 or 40 here at MSK. And you can see here extensive disease in the liver, although perhaps this is a dominant liver mass, but nothing dramatic as we can sometimes see in cholangiocarcinomas. But in her genetic testing, she was found to have an IDH1 mutation, R132C, which has been reported in cholangiocarcinomas. And in fact, Dr. Abu Alfa and colleagues had presented this paper in Lancet Oncology demonstrating the benefit of ivosidenib, a targeted therapy for patients with IDH1 mutant cholangiocarcinoma. So based on her genetic testing, we were able to think of cholangiocarcinoma as being her more likely diagnosis and also to attempt ivosidenib for her. Short-lived but clear clinical benefit when she did receive this therapy. But so I think, again, highlighting the importance of doing this kind of testing. And as we move towards the future, thinking about how we can use this kind of testing, another manuscript from our institution was figuring out how we can use the genetic alterations that are identified to develop a tumor type prediction. And in this manuscript, what we did was, in this manuscript with colleagues in our computational biology group, Penson and colleagues, again presented in JAMA Oncology, we found that based on with the presence of particular genetic alterations or particular features, we were able to make certain cancers seem more or less likely. For instance, in these 3 cancers, all of which having BRAF V600E mutations, based on melanoma seem more likely for this patient who had a particular pattern of genetic alterations that made UV light exposure a likely primary cause of this person's cancer, making melanoma seem more likely. In this person with a BRAF V600E mutation, but also with the presence of APC alterations, made colorectal cancer seem more likely. So I think this is really where our future moves towards in cancer of unknown primary, is trying to figure out how we can include not only our immunohistochemical evaluations and the work of our surgical pathologists in identifying primary sites, but also working together with our molecular pathologists in figuring out how to include all of this information, and almost certainly in the future, figuring out how to work together also with our radiologists as we develop potential primary sites based on patterns of metastatic disease. So thank you for your attention. Apologies for moving quickly here, although a lot of information to cover in this field. Thank you for your attention.
Thank you, Anna, for that very comprehensive talk. It really brought forth a lot of issues regarding the future testings and the capabilities in deciding what kind of targeted therapies we can possibly use. There are a couple of questions in the chat box. To begin with, I would just like to ask you, you mentioned that PET scan is not your investigation of choice to begin with. So are you comfortable with doing just the CT scans of the neck, chest, and the thorax, abdomen?
Great question. Can you hear me okay? Just wanted to confirm. Great. So yes, I think many times patients have a PET scan with they're ordered with the hope that there will be some site that is much more FDG avid than anything else that might make another primary site seem more likely. But truthfully, given that the resolution is better with good high quality cross-sectional imaging, I have almost never seen a PET scan necessarily make a certain primary site be more useful or to identify something particularly small, since the resolution is not great there. So I don't know that it really adds more for me in terms of making a primary site more likely, although I think just a good high quality cross-sectional imaging is usually what I would favor in terms of diagnostic imaging workup. Although I think it's, again, not wrong to order it, certainly, and perhaps there might be a site that does have a higher, SUV or range of FTG avidity that might make something more likely, but in practice, I've not usually seen that. And as we, again, try to be judicious with all of the tests that we put our patients through, especially when they're unwell, that might be one that is reasonable to consider putting off to the side.
Right. So you rely a lot on the pathologist for diagnosing your cancer and the site of cancer. Now, there are questions in everybody is excited with your, mutational landscaping. So is there a role of NGS in the clinic today?
I think so. And I saw some good questions about the role of next generation sequencing in the clinic, as well as a very practical concern about how long it takes to get those results. And here it also takes us many weeks to get sort of comprehensive next generation sequencing results. Generally, at best, when things are going smoothly, and it certainly hasn't been during the last year and a half with COVID here, but generally 4 to 6 weeks. And given how unwell these patients are, we're almost always in a position of needing to start treatments before those results are back. So I agree with starting chemotherapy in the meanwhile while awaiting the next generation sequencing results. I think that's one of the biggest challenges for these patients, is sometimes all of us, patients and clinicians and families, are somewhat paralyzed, sort of doing more and more tests and waiting for more and more information. And the meanwhile, the patient's sitting in front of you getting sicker. So I think you do the best you can with the information you have once sort of a good, thoughtful workup has been completed. So often that means, if you're suspicious for a gastrointestinal primary, starting with Folfox, which is almost always a good choice, whether upper GI or colorectal cancer, and even, a version of that we use in treatments for pancreas cancer as well. So I think starting with a somewhat generic regimen is reasonable while you're working on trying to figure out if you have better, more targeted options, which will come hopefully before you do your first scan.
Right. So Anna, do you rely on tumor markers? If so, what would be your panel of tumor markers when you encounter unknown primary?
Also a good question. And in terms of like blood-based tumor markers like CA19-9, CA125, and CEA, so truthfully, I don't rely on them so much myself. And again, I think I'm probably in the minority here, and I understand because, and truthfully, I probably order them, but I don't know that they help make the diagnosis necessarily. I think they can be more useful as just a marker of disease response. Let's say you check several of those markers at the beginning of someone's treatment and they're elevated. And of course, there might be a easier way to monitor for disease response in addition to symptoms and before you have a chance to do the scans. I suppose the one time that can be helpful is particularly in women, making the distinction between, if someone has widespread peritoneal disease and with ovarian metastases. Sometimes it's hard to know, is this a primary ovarian cancer or a gastrointestinal primary that is spread to the peritoneum? And perhaps if the CA-125 is much more elevated out of proportion to the other markers. That said, exactly as is noted here, it's or as someone I think is starting to talk about these sorts of tests as well. That said, even in the setting I think of peritoneal disease, I've often seen CA-125 be elevated from normal. So sometimes it raises more questions than it answers, but as a marker for disease monitoring, I think it can be very helpful. Truthfully, I almost always end up ordering them, and then whenever I do, I think, I don't know if that helped me, but I think, again, in a situation where you're trying to get the most information as you can from all of the tests we have, very reasonable to order it. And the ones I would usually use here, and this might be my bias as a gastrointestinal oncologist, but probably CEA, CA-19-9, and CA-125, I think can be most helpful for me, although I know there are many others that others order too.
All right. So the last question I would like to ask you is regarding the role of immunotherapy in unknown primaries. Is there any use of testing MMR, PD-L1s, and do you really practice immunotherapy alongside unknown primaries?
Good question. So with the MMR, with immunotherapy, I think like 10 years ago, you might have said, well, it's all just going to be chemotherapy anyways, and truthfully, the outcomes are not great, and you can try different options. But with immunotherapy changing the way we treat lung cancers in particular, and at least in the United States, with our demographics here, that remains sort of the most common cancer that we see. So, in broad strokes for patients with metastatic disease and where those outcomes have really been changed with immunotherapy, I think you do want to make sure you don't miss an opportunity to use that if that could help in a meaningful way. Truthfully, though, I think since at least here in the U.S., PD-L1 is not alone sort of an indication for use of immunotherapies, but mismatch repair is there, but we do have approvals here with the FDA for immunotherapy for patients with MMR deficient cancers. So I also do recommend that, and that we're lucky as part of our NGS panel can be done. So we sort of get all of that information at once. Although, of course, immunohistochemical staining for mismatch repair proteins can be much faster than that. So if you are, if lung is high on your list, on your differential for where this could have started, perhaps disease primarily above the diaphragm in someone with tobacco exposure, et cetera, that can be helpful. There's also, even with the next generation sequencing, if lung is suspicious is high on your list, there's patterns of alterations that are more common in tumors that arise in the setting of tobacco use. And sometimes that can also help with making a diagnosis. And I've had that situation happen also where sort of after the NGS testing, lung seem more likely immunotherapy resulted in a nice response, and it sort of all fits together there. So I think, again, a very good question and an important one, because you don't want to miss an opportunity to give someone immunotherapy if it could help potentially in a very dramatic way.
Thank you. Thank you so much, Anna, for that excellent session. And I would like to thank you and hopefully comprehensive genomic studies will be the future. Back to the